Well, good day, everybody. I think we'll go ahead and get started. I know we're going to be having more participants join as we go on today. Want to welcome you to the webinar featuring the Occupational Therapy Practice Framework, the fourth edition, What's New and Why. My name is Cheryl Castley. I work with Rehab Essentials, and I'm going to be the moderator for today. So questions are welcome, and we appreciate you sending your questions in three different ways throughout the presentation. Please don't wait till the end. We don't want you to forget any of them. So go ahead and send those in, but we will be answering them at the end of the presentation. So at the bottom of your screen, there's a Q&A section where you can feel free to send in your questions. You can also raise your hand on the participation menu, or also send the question in via chat. And we will get to the questions again at the end of the presentation. One of the most important questions I have every time is this session being recorded, or do I need to take copious notes? Well, the good news is it is being recorded, and we will email it out within the next day or two after the webinar. In addition, we are going to be emailing out a PDF of the quick guide with that recording as well that we're going to be talking about today. So focusing on this webinar, you're going to learn a couple different things specific to the fourth edition of the OTPF. And that really includes the evolution, how we got from the initial version to the current OTPF, as well as the purpose of the OPTF, how it contributes to OT as an industry, as well as providing that common basis and summarizing those interrelated constructs that all define the OTD industry. And then the other thing that we're going to be talking about today will be those changes that you see in the OTPF and what those major changes look like. And then, of course, the benefit of using the OTPF quick reference guide that Dr. Lynn has created. It's a wonderful document. You guys will enjoy it very thoroughly. Speaking of Dr. Lynn, I would like to go ahead and turn our presentation over to her and let her introduce herself, as well as Veronica. So Susan, please feel free to take it away.
Thank you. Welcome, everyone. My name is Susan Lynn, and I am the program director for the post-professional OTD program at Marymount University. And I am the current advisory panel member for Patient-Centered Outcomes Research Institute Clinical Trials panel. I have volunteered for the American Congress of Rehabilitation Medicine, AOTA, PCORI, and the Society for Participatory Medicine. I was the research director at AOTA, and my background is in pediatrics. And I will turn it over now to my partner in crime, Dr. Veronica Rowe, to introduce herself.
Thank you, Dr. Lynn. I'm Dr. Veronica Rowe, and I'm pleased to be here and so grateful that you all have joined us. I am the Assistant Program Director for the Transitional OTD program at Marymount University. I have over 24 years of experience as being an occupational therapist, both working in clinical settings as well as teaching occupational therapy. I am very involved in research and enjoy research, and my area of kind of expertise and interest is adult stroke rehabilitation and assessment. I currently collaborate on a lot of different research studies, and I'm always looking for new ones, but I'm very excited to get this program off and going, and want to thank Dr. Lynn for telling us more about the OTPF. Thank you. I'll send it back to you now.
Thank you. All right, let's get started with the next slide. The Occupational Practice Framework has evolved, of course, to the fourth edition, and let's talk a little bit more about how it evolved. It's next slide. It began in 2002 when it was published, and it really was a big deal when it came out because it replaced the Occupational Therapy Practice Framework. The uniform terminology, sorry. And it was much beloved, the uniform terminology. So we all had to get used to the framework. And The practice framework represents the core concepts of occupational therapy and how it can focus on occupation across the service delivery. The domains indicate what we know and our content expertise, and the process indicates what occupational therapists do. Now, in terms of evolution, the AOTA produces official documents and reviews them every 5 years. The review process includes looking at concepts, interrelated constructs, and any advances in the field, including terminology or language changes. There is a look in terms of what's going on internally in the profession, as well as what's externally happening that might have an effect on OT practice. The 2008 version of OT Practice Framework 2 included a couple big changes, such as the addition of rest and sleep. And then the OTPF 3 had some more changes to it. And finally, that brings us to OTPF 4, which is where we had to add 3 more pages to my quick reference guide. And I even had the thought, well, maybe I should not call it a quick reference guide. Maybe it should be the not so quick reference guide. But then my marketing instincts told me that I shouldn't really go with that. So it is still the quick reference guide, even though it's now 5 pages. In terms of what it's not, the OTPF is not a taxonomy or a theory or a model. So it must be used in conjunction with the knowledge and expertise we have, as well as the evidence related to occupation and occupational therapy. So we also should use it within identified areas of practice and with the appropriate clients, groups, and populations. Now, in terms of the OTPF4's purposes, I want you to remember the 3 C's. That is contribution, commonality, and constructs. The OTPF4's first purpose is to articulate OT's contribution to promoting the health, well-being, and participation of persons, groups, and populations through engagement in occupation. It also provides a common basis for occupational therapy, regardless of practice setting. I used to tell my students that if I walk in a hand therapy clinic and it employs OTs and PTs, I should be able to observe and pick out who is an OT in that clinic. Finally, the OTPF4 summarizes interrelated constructs that describe the occupational therapy practice. Now, in terms of why the OTPF was updated to its current edition, I think there are 3 main influencers, and this is the first one: the World Health Organization International Classification of Functioning. And this is the model that commonly describes it. And when it first came out, occupational therapists were really excited because look at the terminology this figure shows. It's using terms like activities and participation, environmental factors, personal factors. And we thought that this is great. There's some synergy, and we can talk about who ICFs model in terms of OT practice. And then, of course, there's AOTA's Vision 2025, which states that occupational therapy maximizes health, well-being, and quality of life for all people, populations, and communities through effective solutions that facilitate participation in everyday living. Now, this Vision 2025 builds on the work of the Centennial Vision, and it will hopefully guide us into the next century. You will find 5 pillars that are supporting this vision statement. These 5 pillars include being effective, and that includes being cost effective. And one of the ways to also be effective is to use evidence and be client-centered. Also, another tenet is leaders. We need OT leaders to be everywhere in terms of changing policies, environments, and navigating complex systems. A third tenet is being collaborative, where we work with clients and with colleagues to produce effective outcomes. And also we want OT services to be accessible, and we also want to be mindful of being inclusive and providing equitable services, and also embracing diversity in all its forms. Now, a third influencer is the Institute of Health Improvement, which is well known for coining the phrase triple aim. And when I served on AOTA's quality team, and we attended the National Quality Forum meetings and conferences, the triple aim frequently came up in conversation. And the triple aim refers to better outcomes, improved patient experience, and lower costs. Now, there also is a quadruple aim, and the 4th aim is improved clinician experience, because the IHI was very mindful of preventing burnout. And this was all before the pandemic. So you can even imagine how more important the 4th aim is in these times. Now, the OTPF has some major changes, including an exciting new category of occupation called health management. What do we mean by health management? Well, if you talk to anyone with a chronic condition, it includes the social and emotional health and maintenance that one has to deal with, and especially for certain conditions, it's not a static trajectory. There are ups and downs, and we have to manage the social and emotional health. There's also symptom and condition management that requires time and energy and resources. So for anyone who has to check their blood sugar, blood glucose levels, or manage their visits to specialists, those are all part of managing your condition. Communicating with healthcare system is also a key task. And sometimes, unfortunately, you have to communicate more than once because balls get dropped, messages don't get delivered, and you have to follow up with healthcare providers. So another key task is medication management. And this doesn't mean managing like the meds in terms of knowing the side effects like a pharmacist would, but it does mean understanding if a client can take their medication safely and on time and in the correct way. Physical activity and nutrition management are also key tasks, and we can certainly increase our understanding of those 2 areas. Finally, personal care device management, if one has a personal care device, including wheelchairs and assistive technology. Now, in terms of context, it was previously called context and environment, and now it is just called context. The change was made to align with the World Health Organization's ICF model. And it includes, let's see, I'm having trouble accessing the PowerPoint. There we go. Virtual interventions, virtual interventions was under context, and it's now under, it was under context in OTPF 3, and it's now considered a service delivery model. So can we go back? Yes, it's now a service delivery mode, which is very timely given the circumstances because everything is happening virtually. Now, in terms of professional reasoning, this is now replacing the term clinical reasoning, and it is probably due to Barb Schell's work. She's written about clinical and professional reasoning. And the Vision 2025 has also hasn't had an influence because it wants to expand occupational therapy out into the community. And this brings us to the difference between the two terms. Why are we replacing clinical reasoning? And in terms of Barb Schell's scholarship, she sees professional reasoning as being more broad. It's a broader term in that it talks about how clinical reasoning is really from the medical science literature, and we want to see occupational therapy out in the community. So consultative settings such as school systems, management, and community health don't really fit as well under clinical reasoning. And so professional reasoning is a broader term that we can all use to describe anything that an OT practitioner does in any setting. And as far as application of this change, if you are in academia and your courses or sections of courses talk about clinical reasoning, you might want to consider changing it to professional reasoning. Fortunately for us at Marymount University, we start in January in 2021, and we have a professional and ethical reasoning course already lined up. So that's just an example. In terms of preparatory methods and tasks, if you use physical agent modalities, you're used to calling it preparatory methods and tasks, and it's now considered a intervention to support occupations. It should be used, of course, to prepare clients for occupational performance, and it should also be considered part of a home-based engagement program to support daily occupational performance. Examples of the interventions to support occupations are listed below. They include mechanical modalities, orthotics and prosthetics, assistive technology and environmental modifications, wheeled mobility, and self-regulation. Another big change is the focus on groups and populations. OTPF 4 has a performance skills for groups, as well as performance patterns for group and populations. And in terms of application of this knowledge, if you have a curriculum, if you're in academia, and you might want to look at the curriculum to see if you cover population health. At Marymount University, our Prevention, Disability, and Health course covers individual health, prevention and disability, all the way to a population health context. And so that course will cover things like health promotion, wellness, public health, and social determinants of health. Now, in terms of client factors, the gender and identity was added and as a client factor. You will find it under experience of self and time. Psychosocial was also expanded, and it is now in general mental functions. And then the term interoception was added under body functions. And for those of you who don't know what interoception means, I had to look it up just to be sure. It means sensing and awareness from one's internal organs. And that some examples include hunger, thirst, and my personal favorite, craving for chocolate. In terms of other changes, there is a more explicit description and definition of the following terms: occupational science, occupation, and activity. And the process of OTPF now includes some new terms such as transition and discontinuation. Transition, of course, refers to moving to a different setting or environment, such as going from high school to college. And discontinuation refers to discharge or termination of services. And as far as outcomes go, there is an increased emphasis on patient-reported outcomes, or PROs, and the PROs are now very commonplace in the medical literature. It's almost like medicine has caught up and realized the value of having patient-reported data, and a suite of PROs that you might want to look into is called PROMIS, PROMIS. There are now PROs on almost every possible topic, such as pain, self-perceived health, satisfaction, depression. So there's PROs on almost every topic. In terms of the cornerstones of OT practice, there are 4 cornerstones, starting with the core values and beliefs rooted in occupation, the knowledge and expertise in the therapeutic use of occupation, and the professional behaviors and dispositions, and finally, therapeutic use of self. Cornerstones are thought to be foundational to the success of occupational therapy. And I think some earlier criticisms of the OTPF framework was about the omission of the therapeutic use of self. So those critics should be very happy that it is front and center as a cornerstone. And these 4 cornerstones are not hierarchical, and they each can influence the other cornerstones. There's also a long list of complementary contributors, and all of these, I believe most of you know. They include evidence-informed practice and theory-based practice, occupation-based practice. All of these contributors are thought to influence the cornerstones. And cultural humility is just about being aware of one's biases and values in terms of culture and reflecting upon it and thinking about others' cultural values and being respectful. Okay, now we can talk about the quick reference guide, and it is 5 pages long. I will give you a little orientation to it. When you receive it, anything that's in red font means it is new. And anything that is in blue font means the definition has changed. Now, I will just issue a disclaimer that maybe I didn't catch every possible change. So if you find something, you can feel free to contact me and I will update it and share that. But when I first created a quick reference guide, it was a 1-pager, and I found it helpful in teaching. So let's take another look at the quick reference guide. It is a time saver because you aren't flipping through as many pages. And as far as uses go, clinically, I think it would be helpful for student training and as a guide for practice, especially when you are looking for certain terms, maybe like all the aspects of context, or if you want to check that you've covered all the motor and process skills. It's probably too long to use for documentation purposes, but it might be useful for documenting case studies and taking a look at challenging cases. So I can see its usefulness in those situations. Of course, in education, it comes in handy when you are writing and looking at cases. When I taught in a problem-based learning environment, we used the quick reference as whenever we had a new case. And so the students became familiar with using the OTPF on a daily basis. And then the quick reference guide was helpful for grading purposes, just to make sure that the students had thought of all aspects of a particular category. And it could be helpful in program development and evaluation as well. And finally, I think that, and this is just my opinion, but the framework serves as a bridge between where we are and where we want and need to be. And I think if we have a consistent use of the framework terminology and the process of occupational therapy, we could see occupational therapy thriving into the next century. So with that, I'm going to conclude the webinar and welcome your questions. You can feel free to type them into the chat box, and I'll turn it over to Cheryl.
Wonderful. We do have a handful of questions that have come in. As a reminder, everybody, if you have any questions, please feel free to send those in via chat, via the question and answer, or raise your hand. and we'll take all the questions as they come in. We have a couple more minutes left in the webinar, so definitely have time for everyone's questions. As a reminder, this webinar will be emailed out along with that quick guide that Susan just presented. On screen here, you will see, we thought I'd give you a little bit more time to go ahead and take a look at how this functions in terms of the process and domain that Susan was presenting a little bit earlier. So going on really quickly, the very first question we have is, how do I access the original OT Practice Framework 4th edition? Susan, would you be so kind as to answer, just give that a little bit of a rough answer? And I think that I've got a link that I know that I can send you guys as well, but Susan, if you want to go ahead and answer that, that would be great.
Okay, sure. The OT Practice Framework, there are two versions of it. One is an AJOT, and it was published in August 2020. So if you are an AOTA member, you can access that freely online. Just go to AOTA's webpage and then find the August issue. It's also listed as one of the most commonly accessed documents. So you can click on that link and access it there. And so that should be free to you if you are a member. Now, AOTA also sells a booklet about it, and that is $39 if you're a member and $99 if you're not a member. So you can order that through the AOTA marketplace.
Perfect, thank you. And I did send out a couple of those links that Susan had just mentioned. So you should be able to find those as well in the chat. I do have a couple other questions that have been coming in. The first is, am I able to share the quick guide with other faculty members at our university?
Yes, you may. In fact, when I first had the original OT Practice Framework quick reference, it's like a one-pager right here. I think we sold it at a state conference for $1 or $2 each, just as a fundraiser for the Student Scholarship Fund. So feel free to share it. I'm hopeful that it will be helpful to all of you. And a fun fact, I even shared it with AOTA when I was there, and they kind of nixed my idea of sharing it widely. So now that I'm not there, I can share widely.
Perfect. Thank you, Susan. I know you talked a little bit about this during the presentation, but maybe you can expand on it a little bit. But the question is what do you think is the biggest change to this version of OTPF that is relevant to clinicians?
Oh, yes. That is probably by far the therapeutic use of self. I think it's just a really nice highlight in this edition that therapeutic use of self is front and center. And I think it also speaks to the craft of providing therapy. There really is an art to it, and I don't think it gets much attention sometimes as it should.
Wonderful. Thank you, Susan. Our next question is, again, more specific to the quick guide. The question is, please provide direction as to how professors can use the quick guide with students. And then you kind of answered this a little bit, but is it freely available to copy and or post, and is it available for students to purchase? So a little bit different, you talked about that, but can you talk to how they can use the quick guide with students?
Yes, so I found it very useful when we did case studies, and I could just say, pull out your quick reference guide and let's analyze this case in terms of client factors, in terms of whatever area that your case is focusing on. Maybe at the very beginning of of the curriculum, you just want them to identify the domains, the areas of occupation kind of focus, like which occupations are being affected by this person's condition. So you can use it in many different ways. I found it helpful in grading papers because if they're doing an activity analysis, if they're writing up an analysis of a case, you can see if they've thought of all aspects of that particular construct. And Cheryl, was there another part of that question, or did I answer it?
You had previously answered about if you can distribute it and if it's free to students, and you had said that they can definitely distribute it. And again, as a reminder, I will be emailing that out in the next day or so as well. We do have one additional question that came through. Do you feel that professional reasoning versus clinical reasoning will make it more imperative for therapists to be more well-versed with the OTPF to show the distinct value of OT?
Yes, I think that professional reasoning does open the, I guess, doors a little bit more so that we are thinking about OT outside of the medical setting. And I think that that's a great thing because we are seeing lots of changes in healthcare delivery modes right now. CMS is actually starting to pay for telehealth, and more insurance companies probably will follow CMS's lead. There are some great things happening in terms of telehealth within OT. My state, Virginia, has just decided to join the licensure compact, which is going to try to get at least 10 states involved, but that means there's licensure reciprocity between those states. So that would be great for telehealth because you can't legally practice unless you are licensed in the state of where the client lives, as well as the state where you are in. So having that licensure compact will be helpful to facilitate telehealth. And there is a big, steep price to get into that compact, but my state association has a plan. So we might be fundraising for the next 5 years, but we really see the value in being in that.
Wonderful. Thank you, Susan. Okay, the next question has a little bit of a different focus, but is the difference in health management that it was moved from IADL and elaborated on?
Trying to understand the question here. So can you read the question one more time?
Absolutely. And the question was, is the difference in health management that it was moved from IADL and then elaborated upon?
Okay. Yes, I think I think there's a realization that it is an occupation in and of itself. It really, truly is a big endeavor. And when you think of the number of people with chronic condition, I think it speaks to all those little things, all those tasks that we talked about that make up health maintenance. And it's not just, health maintenance in terms of, oh, you go to the gym and, oh, you get your physical once a year. For those with chronic conditions, it is much more than just, maintaining an ideal weight and eating mostly healthy all the time. It's a whole nother skill set. In fact, in another organization that I belong to, Society for Participatory Medicine, we have many patient advocates and clinicians who say, we need to empower patients to be able to speak up and help articulate their preferences and values for their healthcare decision making. Because some, physicians, they feel like they're the experts and they tell the patient what to do, but that's not shared decision making, which is what we like to see in healthcare. And I think OTs naturally know how to do that. So having all the tasks associated with health management, I think is a really helpful thing when we're talking about those with chronic conditions.
Wonderful. And we received a comment that's similar with regards to health management. So I'll just go ahead and read the comment and then kind of give you an opportunity to also add anything you'd like. But the comment says, I would hope having health management as a separate identified occupation may support establishing OT participation in primary care. Do you have any thoughts on that, Susan?
Wow, that would be so great because, physicians, they don't really have time to go into problem-solving mode with clients and patients. So that would be wonderful if OTs had a bigger role. I know some OTs already do participate in primary care, and that's wonderful. So if we could have a sustainable model, because of course it all comes down to cost, if we can show OT's value in that setting, as well as the outcomes, that we get better patient outcomes from having OTs in primary care, that would be fantastic. And basically we also need to show that it's cost effective. So if reimbursement agencies could see that value, then I think it would go a long way in helping to facilitate OT's role in primary care. So thank you for that comment.
Wonderful. Going along a little bit of a different line, do you have any tips for students who struggle or are confused with client factors and performance skills at times?
I think there are some examples in the framework, so you might want to check it out. But also, I think there are, I don't know if any of your texts have examples of case studies, but if your curriculum does not, you can also suggest that to your faculty, that you would like more case studies that show the difference. Client factors are I think are more of a within a person, and then the performance skills are more of a you can observe, because it's a doing aspect of performance. So you should be able to observe and measure it or describe it in some way. But yes, that's a good question, and I think it's kind of like the skill of splinting. The more you do it, the more comfortable you'll feel about doing it.
Thank you. So we have another question that's a little bit more specific back to the OTPF 4. Do you know if the AOTA occupational profile template will be updated to match the OTPF version 4?
Yeah, I remember the OT profile being talked about even when I was at AOTA, and I do not know its current status. I think when I left AOTA in 2015, I think they were talking about making the template available for use, but I don't know its current plans, AOTA's current plans. It might be a good question for Deborah Lieberman, who is the Vice President for Practice Improvement, and she might be able to know who or if that is the plan.
And it looks like we just got an update from one of the members, and it said it is in the process of being updated right now.
Great,
So,
thank you.
Perfect. Thank you, Susan. Okay, we do have a couple more questions here, but just so everyone know, we've got about 10 minutes left in the webinar. Please feel free to keep sending in your questions. We will actually be able to stay around a couple more minutes. If there's extra questions, then there is time. So please feel free to keep those coming. And if you want to answer after the fact, please just let us know that as well, and we can email you an answer as well. And then really quickly, just in case folks decide that they would like to go ahead and just listen to the recorded questions later. Do want to provide some contact information briefly for you. So on the screen right now, you can see Susan's contact information with us over at Marymount. And then we also do have the website for our program in case you have any OT program specific questions, or our email at the bottom there. Please feel free to use that or to contact me via the email you received with the webinar invitation, and we'll be happy to do that. Have gotten a couple different thank yous. We really appreciate the feedback and input, and we appreciate you being here today. With that, I have a couple more questions that we have. So one of them is, why do you call it a framework and not a taxonomy or a model?
So that's a great question. And although I'm not an author of this document, I'm going to take a guess that the use of the word framework is just like to imply that it has a structure. So it is not a taxonomy in that it's not trying to capture every little thing and catalog it. So actually, I think AOTA wants us to use the word OTPF instead of just framework. And because there are many frameworks out there. So they want to sort of highlight that this is just the Occupational Therapy Practice Framework. But yeah, I think they just wanted to convey an overall structure for our terminology and our process.
Perfect. The next question is a little bit off topic, but I think it's interesting. It seems like the OTPF is really looking at going from just focusing on the individual to also focusing on health population or population of the health as a group. Is this something that you think will continue and expand upon? And do you think that the current pandemic is a model of why we should continue to do that?
Yes, I thank you for that comment and question. Yes, I do think that it is sort of pushing us, as a profession towards population health. And I think that is a wise way to go. We know our colleagues in physical therapy are doing the same. So we want to be concerned about what we can do, our role in creating population health and facilitating that. And we do that in so many ways, right? I know OTs who have, been involved in changing the environments of workplaces and museums, just so that people of varying capacities and sensory processing aspects can participate in those environments. And so that is almost, one view of group health. We're making part of the environment more welcoming for other groups of people. And that's a great way of facilitating participation, right? So even if you've got only one showing at the movie theater where it's not blaring sound, then that group of people can now participate in going to the movies. So I think it's a wonderful way, especially in the pandemic, of focusing on population health and what we can do. And I think a big example here, given the pandemic, is how we can help with coping strategies, right? Everyone is having a hard time. And I think if we just showcase some ways of healthy coping versus unhealthy coping, that could be helpful.
Wonderful. Yes, I know that population health is definitely a hot topic these days. So that's very informative, Susan. Thank you. Okay, we actually are coming down to our last question of the session. Please feel free to go ahead and continue to send us any questions, and we will get to those. After the webinar, we can send you some email questions, or if you find any, please feel free to reach out via the contact information I mentioned. But the last question comes to us, and I may need to read it twice because it's multi-part, but how do you envision the new emphasis on populations playing out in terms of prevention and covered services? Do you see this as a researchers conducting efficacy studies and providing this information to policymakers at CMS or something else?
Yes, that's a great question. I do think we need to have evidence when we go to policymakers. I mean, we can make our pitch that we should have a role and be at the table, but if we don't show in what ways we can be impactful and have cost effectiveness, and sometimes it does cost more to have better health, but you can measure cost in so many different ways, right? Reduce trips to see healthcare provider, or greater number of days spent at home, versus in an institution, then we can use those metrics as well. So there is a definite need for researchers to capture this data, and I think the OTPF 4, the emphasis on outcomes, is a good one, because we really need outcome data. And as far as, that's a whole nother topic about outcome studies, but we really need efficacy as well as effectiveness studies. So any researchers out there, this is your time to shine, right? We really need your expertise here.
And we do have another comment as well relating to the framework. And it comes in from Paula Kramer. And Paula, I'm going to go ahead and unmute your mic here for a second. She had just mentioned that the framework terminology was meant to really frame the scope of the OT practice. I do want to go ahead though and thank everyone for coming very quickly again. And Paula, you should be able to unmute your mic and talk a little bit more about that.
Thank you. Susan, thank you for a wonderful presentation. I think the reason it's called a framework is it's meant to frame the scope of OT practice. It is not a taxonomy because it isn't meant to define terms in a hierarchical manner. And it is not a model because it doesn't tell you how to practice or give you an idea or follow for that, but it frames the scope of OT practice, and I think it does it well. I think the changes that they've made are very constructive to our practice, and it's a very positive thing to come more in line with the ICF.
Yes, thank you, Paula. It's good to see you virtually.
Good to see you too.
Wonderful. Well, thank you again, all. We are going to go ahead and bring the webinar to a close. Again, if you have any more information or any questions you'd like to share, go ahead and please feel free to email Susan or myself, and we will get back with you. In the meantime, thank you so very much. Have a great day, and please stay safe.
Yes. Bye, everyone. Thank you.
Bye. Thank you.